Hey everyone, and welcome. Today, we are going to tackle a skill you absolutely have to get right in nursing practice: blood transfusions. And look, this isn't just about passing a test. This is about feeling confident and knowing exactly what to do in a situation that can literally save someone's life. So, you ready to feel like a pro with this? Let's dive in. So, here's how we're going to break it all down for you, just like a study guide. First, we'll get familiar with our tools, all the different blood products. Then we'll get into the why. Who needs what and for what reason. After that, it's all about the how, that critical step-by-step safety process. We're also going to get you ready for when things go wrong by covering transfusion reactions. And to pull it all together at the end, we'll drop you right into a case scenario to really sharpen that clinical judgment. All right, first things first, we have to know our tools. Before a single drop of blood goes into that IV, you need to be an expert on where it comes from and what it does. So let's start with the basics of donation types. Okay, so there are two main ways this happens. You've got your standard donation, which is what most people think of, blood from a compatible donor. But check this out, autologous transfusion. This is such a smart move for patients having elective surgery. They can actually donate their own blood for up to 6 weeks before their procedure. And get this, as long as their hemoglobin stays stable, they can even donate weekly. It's basically their own personal super safe blood supply. All right, let's put this to the test with a quick question, just like you'd see on the NCLEX. So your patient wants to do an autologous donation. Which of their statements tells you they actually get it? Remember what we just said about the timeline. The key is knowing that they can donate weekly, but only if their hemoglobin holds up. That's the piece of info that shows they really understand the process. So now we know the what, let's talk about the why and the who. Why does this specific patient need blood, and which product is the right one? This is where we get into the real nitty-gritty of connecting a diagnosis to a treatment and understanding the absolute science of blood compatibility. Think of this slide as your mental cheat sheet. Seriously. You've got a patient with massive blood loss or severe anemia. What are you thinking? Packed red blood cells. A patient with a clotting disorder like hemophilia. You're thinking fresh, frozen plasma. Low platelet count or thrombocytopenia? Platelets it is. Making these connections in a split second, that's what good clinical judgment is all about. All right, this chart right here, memorize it. Know it backwards and forwards. It's not optional. Here's the deal. Your blood type is named for the antigens on your red blood cells. Then your body creates antibodies against the antigens it doesn't have. It's that simple. That's why type O with no antigens is the universal donor. There's nothing for the recipient's body to attack. And type AB with no antibodies is the universal recipient. It won't attack any blood type. Oh, and don't you ever forget the RH factor. It's simple. Rh-negative patients can only get Rh-negative blood, period. Okay, this section is where the rubber really meets the road. This is your safety checklist. These are the steps you follow every single time, without fail, no shortcuts. This process is what keeps your patient safe from a catastrophic error. Let's get into it. Let's walk through this. You start with the basics. Verify the order, get consent, and grab those baseline vitals. Then you get a good large bore IV going. But now I need you to laser focus on these next 3 steps. The 2-nurse double check, that is a non-negotiable safety step. You and another RN are matching that patient's armband to that blood tag, word for word, number for number. Next, you prime your tubing with 0.9% sodium chloride, and only sodium chloride. And finally, the golden rule. For the first 15 to 30 minutes of that infusion, you do not leave that patient's bedside. That is the prime window for a major reaction. Now, when we're talking about our older adult patients, we've got to tweak our approach a bit. Their bodies are just more sensitive. So we might use a slightly smaller IV gauge. We absolutely have to check their kidney function and fluid status very carefully. And we're going to run that transfusion slower, usually over 2 to 4 hours. Your job is to be on high alert. We're talking vitals every 15 minutes for the entire transfusion, and you are watching like a hawk for any sign of fluid overload. Hearing crackles in the lungs? That is a huge red flag. Okay, so we've talked about when everything goes right, but what about when it goes wrong? This next part is about being ready for those worst-case scenarios. We're going to go through the major transfusion reactions, how to see them coming, and exactly what you need to do to protect your patient when every second counts. This is the big one, the one you pray you never have to deal with, an acute hemolytic reaction. It means the wrong blood type was given and the body's reaction is immediate and violent. 2 signs you have to burn into your brain: sudden, low back pain, and the patient saying they feel a sense of impending doom. If you hear that, you don't think, you don't wonder, you act. You hit stop on that pump immediately. That's step 1. Then you disconnect the blood tubing, start fresh saline with new tubing to keep the vein open, and get help. Okay, a febrile reaction. This one's a bit more common. It's basically the patient's body reacting to the white blood cells in the donor blood. Your big clue here is a spike in temperature, at least 1 degree Celsius or 2 degrees Fahrenheit. Your first move is always the same. Stop the transfusion. Then you'll give something for the fever. But the real lesson here is for next time. If a patient has this reaction once, they will need a special WBC filter for any future transfusions to prevent it from happening again. Allergic reactions are tricky because they can be anything from just a little itchy to, well, life-threatening. If your patient just has some mild itching or hives, you'll stop the infusion, give an antihistamine like Benadryl, and the provider might even have you restart it slowly. But if you see any signs of anaphylaxis, and I mean wheezing, trouble breathing, a drop in blood pressure, that is an emergency. Stop everything. You need to be thinking epinephrine now.
A bacterial reaction is every bit as bad as it sounds. You are essentially giving your patient a dose of sepsis right into their veins from contaminated blood. The symptoms look just like sepsis: wheezing, hypotension, shock. You know the first step. Stop the transfusion, but right after that, you're going to be thinking about antibiotics and getting a blood culture sent to the lab so we know what kind of bacteria we're fighting.
Now, this last one, transfusion-associated circulatory overload, or TACO, is different. It's not an immune thing. It's more like a plumbing problem. We've pushed too much fluid in too fast. Look for those classic signs of fluid overload: crackles in the lungs, shortness of breath, a cough, and that big, bulging jugular vein, JVD. Here, you might just need to slow the rate way down or stop it. Your next move is to sit the patient straight up, get their feet down, and get ready to give diuretics to help pull off all that extra fluid. Whew, okay, that was a lot of crucial information. But knowing it is one thing, applying it under pressure is another. So let's put it all together. I'm going to give you a scenario. You're the nurse. What are you going to do? Okay, picture this. You're in the room, it's been 15 minutes since you started the packed red blood cells. Your patient suddenly starts shivering, telling you they feel cold. You grab a set of vitals, their heart rate is up, and their blood pressure is dropping. And then they say it. My back really hurts. Okay, take a second, really think. You've got all the pieces of the puzzle right in front of you. What is your absolute #1 first priority action in this exact moment? If you said stop the transfusion, you are 100% correct. That perfect storm of symptoms, the low back pain, the chills, the vital sign changes, all happening within that first 15 minutes is screaming acute hemolytic reaction. So here it is. This is your memory anchor, the one thing you take away from all of this for the NCLEX and for your entire career. For any suspected transfusion reaction, no matter how mild you think it might be, your first immediate, non-negotiable action is to stop the infusion. That is the single most important thing you can do to protect your patient.